in a minute or so.
Recording in progress.
Why don't we give people another minute or so to wander in, and then we'll start the session, okay? All right, why don't we go ahead and get started. Once again, welcome to the November edition of the PGSSC Global Research Seminar. I'm really excited today as we're going to discuss a topic that is near and dear to my heart, and I hope will, for those of you who may not be as familiar with it, will introduce you to some concepts and around how we think about climate change, environmental sustainability, and surgical care. So I would ask you guys to please fill out the Menti link that Bethany had sent. I think the research team is very interested in figuring out where people are calling in from, and we will make sure that that gets posted. Okay. So without further ado, let's get going. As you guys know, the research seminars are 8 sessions. This is the one we're going to talk about today, and videos are going to be posted after the seminars. There is a broad research team led by Adeline and Bethany, but Kate, Maureen, and Afra are also very involved and have done a lot of work to put these together. So, without further ado, I would like to introduce our first speaker. Dr. Jonathan Slutzman is director of the Center for Environment and Health, and the medical director for environmental sustainability at Mass General Hospital. He practices clinically as an emergency room physician at MGH, and is an assistant professor of emergency medicine at HMS. Dr. Slutzman holds a degree, bachelor's in civil and environmental engineering from Princeton. He an intern engineer certificate from the state of New York, and then went to med school at Albert Einstein College, where he obtained his MD with distinction in disaster medicine. Prior to a career in medicine, Dr. Slutzman, as evidenced by his background, was a consulting environmental engineer, completing projects in a variety of areas within environmental health and safety assessments. These included industrial facility audits, commercial and industrial site assessments, environmental life cycle impact assessments, which is incredibly relevant for the paper we're going to talk about today, one of the papers, and disaster management exercises. He's completed work on medicine and nuclear war, suburban flood hydrology, healthcare cost modeling, and environmental life cycle assessment of healthcare processes. So I think Dr. Slutzman is in a unique position to give some real insight in the article about the Canadian healthcare system today. His academic focus is on the cost, both financial and environmental, of healthcare, and he's a founding member of the Mass General Brigham Clinician Sustainability Group, past chair of the Society for Academic Emergency Medicine, Climate Change, and Health Interest Group, and advisory committee of the Healthcare Without Harm Physician Network, and a founding member of the MGH Executive Sustainability Committee and Mass General Brigham Climate and Sustainability Leadership Council. So very impressive resume, very well-informed person to talk about this article today. And Dr. Slutzman, I will turn it over to you, and thank you in advance for coming and sharing your insights.
Thanks much, Craig, for the lovely introduction, and it's my pleasure to be here. I love talking about environmental sustainability and climate change and health. I am also happy to be interrupted, so if questions come up and I don't necessarily see your hand up, or you put something in the chat that I don't necessarily see because my screen is all set up differently, feel free to interrupt, and I'm happy to kind of take the discussion in places that you all want to hear much more than what I might think I might want to talk about. So today we're going to talk about environmental life cycle assessment in healthcare, with a particular focus on that one paper measuring the environmental impacts of the Canadian healthcare system. I do have some disclosures that basically say that some organizations have given me some funding to talk to them about healthcare sustainability, or to teach primarily physicians about healthcare sustainability, or to advise on how to make healthcare more sustainable. There's a clear theme going on there. So the first question is why should we even care about environmental sustainability in healthcare, right? We're in the business of saving lives. I worked last night in the emergency department at Mass General. I got home about 45 minutes ago. And clearly our job is so important that we save these lives, that we bring whatever resources we can to bear to do that. Why should I necessarily care about what my environmental impacts are when there are so many other industries that are polluting way more than healthcare? And one answer that I would give you is 125,000. 125,000 is an estimate of the number of people who we kill every year from healthcare pollution in the United States. So 1 year of climate change and other environmental pollution from healthcare as a service kills 125,000 people each year going forward. That's a lot of people. Pollution would be the third largest cause of death. Overall pollution, not just healthcare, would be the third largest cause of death in the United States. So it's kind of a big deal. It's a really big deal. If the US healthcare industry were its own country, it would be the 13th largest emitter of greenhouse gases on the planet, emitting more than the entirety of the United Kingdom, and I believe also South Korea. If healthcare as a whole, for global healthcare industry, were its own country, it would be the 5th largest emitter of greenhouse gases on the planet. So we are part of the problem, yet we have a moral imperative not to be harming our patients and our communities. So it's important that we provide the care that we do in as environmentally responsible a way as we possibly can. So that gets us to the question of how do we know what might be more environmentally sustainable than some other options that we might choose. And that gets us to the entire field of sustainability science, which is an established, mature field. Healthcare is late to this party. Industrial ecology has been around for decades and decades and decades, looking at many, many other industries. But the idea is we should look at the interactions between natural and social systems so that we can meet the challenge of sustainability, which is to provide for the needs of the present generation without impairing future generations' abilities to do the same for themselves. So basically, we have a closed system on the planet. How can we live within our means so that we're not extracting more resources than would be available? So the paper we're going to talk about today is a life cycle environmental emissions and health damages from the Canadian healthcare system, and economic environmental epidemiological analysis. There are a lot of really big words that I'm going to try and summarize and boil down to make this a lot simpler than it might seem, by a few of my colleagues. I have to disclose, I did not work on this paper. I have worked with all three of those folks. They are all on research teams with me, or more accurately, I am on research teams with them. I know them very well personally, so I can talk about this work, and I do similar work, so I know how it's done, but I was not exactly involved in this particular study. So let me touch a little bit on the team here, because that's really important for understanding how to do environmental studies in healthcare. There are three folks there. You'll notice on the affiliations that you have somebody from the Department of Civil and Environmental Engineering, that's Matt Eckelman. You have somebody from a Department of Anesthesiology, so that's Jody Sherman, and you have somebody from a Department of Surgery, Andrea McNeil. They are each from different institutions. Matt's in Boston at Northeastern, Jody's at Yale in New Haven, and Andrea is at the University of British Columbia in Canada. But the key here is that each person brings their own perspective. You have an environmental engineer who really knows how to measure these emissions and the allocation problems and the techniques exceptionally well. You have an anesthesiologist who also happens to be a medical director of environmental sustainability for a health system, so understands the intersection of clinical care and the administration to provide environmentally responsible care. And you have a surgeon who clearly is involved in direct clinical care on a daily basis in what is considered to be likely the most environmentally intensive form of care that we can provide in operating rooms. So it's a broad team that bridges the clinical and the engineering to get the right expertise to bring these studies to bear. I'll tell you from reviewing a number of manuscripts, I have read manuscripts that are written by clinicians only. I have read manuscripts written by engineers only. Neither group can do the study well. And there are critical flaws when we don't have that melding of environmental engineering expertise with clinical expertise. So this title, Life Cycle Environmental Emissions, blah, blah, blah. I'm going to boil it down. It really just means we're measuring the environmental pollution and the health effects from that pollution from an entire healthcare system, in this case, Canada, using a cradle to grave approach, life cycle, not just one little bit, the whole thing for all of the inputs and outputs. So raises the question, what does life cycle assessment mean? It's a tool that's been around for, at this point, about 70 years, used in industries around the world, predominantly not healthcare until fairly recently, maybe the last 10 years or so. It's a tool to quantify all of the environmental impacts of a product or a process holistically from cradle to grave, meaning raw material extraction, transportation, manufacturing, refining, more transportation, use, reuse as appropriate, and ultimately end-of-life disposal of that product. You can also look at a process that way, since processes are really just made of individual products along the way, to get all of the inputs and outputs. There's an established international standard for doing life cycle assessment promulgated by the International Organization for Standardization, ISO. It's the, if you really are interested, it's the 14040 family of standards. And if you're really interested, you can ask me later and I'll be happy to send you copies, but they're regulatory documents that are they're excellent reading if you need to go to sleep. There are 4 steps to a life cycle assessment, and they are interdependent with lots of iteration along the way. So it's not like you do step 1, then you do step 2, then you do step 3, then you do step 4, and you're done. You do step 1, then you do step 2, then you realize you need to edit step 1, and so on, and you iterate to get the best study possible. The first is, what is your goal and scope? Then something called an inventory analysis, where you quantify all of the inputs and outputs of your system. An impact assessment, where you translate those inputs and outputs into some impact categories that you decide along the way which impact categories you're interested in. Those impact categories could be things like global warming impact, or human health cancer impacts, or ecotoxicity impacts, and so on. Generally, environmental impacts with some human health touched on as well. And then the last part is interpretation analysis. How do you put that in context? How do you understand how these data fit into your values and what you're going to do with them? There are two primary ways to do a life cycle assessment, and we call them process and we call them input-output. You can really think of them as bottom up or top down. Imagine for yourself a system, and if you're a clinician, you can think of a really simple system of a primary care office visit might be your system. And what are the inputs and outputs there? You have patients getting to the clinic, you have the physician and the nurse and all the other clinicians getting to the clinic. You have the clinic itself where you have to have heating and ventilation and cooling maybe, and you need lighting. You need some equipment in there. You need supplies to clean that equipment after the visit. You might have some paperwork, so that gets put in as an input. And then depending on the visit, maybe you need some other supplies like bandages or dressings or whatever it is as part of this clinic visit. And then your output might be taking care of a patient for a year as a primary doctor. And so you define your functional unit, the functional unit for your study being, what am I getting out of this? There's some great, hilarious examples that are very, very serious. One of my favorite life cycle assessment studies ever done is from the early 1990s. It was commissioned by Procter & Gamble, the consumer goods company, about diapers. And it was disposable versus reusable, disposable versus cloth diapers. And the functional unit there was diapering an infant for 1 year. That's the functional unit. And then from that, you define what are the processes, the products, the inputs and outputs necessary. So here we have, from the ISO standard, a prototypical product flow, a system environment. Everything inside the box you're defining inside your system, everything outside the box you're not. And there are lots of things that go in and out and around within it. A process LCA takes each of those and all of the inputs required and all of the outputs resulting, which might be pollution, it might be heat, it might be various things, and sums them up from the bottom. So you get a very detailed look at everything that goes in and comes out. As you can imagine, for most systems, this is fairly labor intensive. It takes a lot of effort to get each of those individual pieces and to add them up. That works great if you're looking at a system that's relatively small, that's self-contained, and about which you have a lot of knowledge or control. So imagine, say, a soda beverage manufacturer where they control the bottling and the formulation, and they want to know what are the life cycle impacts, environmental impacts of bottling a can of Coke. And so they would know, okay, what goes into making a can, what kind of energy is required, what materials are required, and so on. But in this study, we're looking at a health system, the entire health system of Canada, which is large, and there are lots of moving parts. So being able to add those from the bottom up would be prohibitive. There is no way that you're going to be able to do that. So we have another method, the top-down method, which is economic input-output. And I'm sure none of you got the memo that we were covering linear algebra and matrix functions in this talk. So pay careful attention because you're never going to need to know this. So the way that you do top-down is all developed countries, for the most part, produce what are called economic input-output tables, generally each year, but not necessarily. It could be every other year, it could be every few years, that describe the economy, where you have the products from one economic sector, one industrial sector, flowing to every other industrial sector, usually in terms of currency. So in the United States, it's done in US dollars. In Canada, it's Canadian dollars. In the United Kingdom, it's in pound sterling, and so on. So you get these tables, and what you can do is you can use those economic input-output tables, extend them to include environmental impacts, so that ultimately you end up with an emissions factor. so that every dollar I spend in air transportation is responsible for a certain amount of greenhouse gas emissions, carbon dioxide and other greenhouse gases. And I can do that for each economic sector so that essentially I get a translation to dollars and emissions. So that whole matrix table boils down to this much more simple form, which is that the total emissions are just the sum of my spending in each sector multiplied by the emissions factor for that sector. So you're going to have an emissions factor for transportation, another one for, say, medical devices, another one for electricity, and so on. And you get these from these giant tables. Here is literally one of 16 pages of the United States economic input tables from the US Bureau of Economic Analysis from last year. And what you'll see is pretty interesting things. For example, let's just look at the very top row. You have an industry called farms. And farms, the biggest industry to which farms sell is other farms. So $156 billion in economic transactions from farms to farms, and then 436 million from farms to forestry, and so on. So you can use those to create the emissions factors in the same way. It seems really complicated, but it boils down to be very, very simple and feasible for these top-down measures. So what Matt and Jody and Andrea did in this study looking at Canada was they took the Canadian National Health Expenditures, which is another bit of data that are compiled by the government of Canada every year that says each year we're spending this much in healthcare and this is where it's going. And they correlated it with commodity codes that exist in the economic input-output tables, to which they could apply environmental emission factors. So you see that the Canadian National Health Expenditures includes spending on private hospitals, spending on public hospitals, spending on physicians, spending on prescribed drugs, non-prescribed drugs, and so on. And each of those categories was translated to a commodity code in the economic input-output tables. This right here, this translation, is probably one of, if not the most important piece to get right, or get as close to right as possible when doing an environmentally extended economic input-output life cycle assessment, or the top-down method, because that translation is fairly sensitive. So you get that, and you get the dollar numbers, which exist. We're not going into the individual calculations here because that's actually not the interesting part. And from that, you can get, for example, greenhouse gas emissions by each of those health expenditure categories. So what you see here is in one of the years that were studied, each of the years that are studied, you have the total greenhouse gas emissions in metric tons for each of those categories of spending in the Canadian healthcare system, for a total from 2009 of just under 30 to 2015, 33 tons, which is a fairly large number, but I'll tell you it's immensely smaller than it is for the United States, and we'll catch that later. And you can see where the hotspots are. So really what you notice are drugs, prescribed and non-prescribed, are about a quarter of the total emissions in the Canadian healthcare system. And hospitals are just under that, also almost a quarter, not quite. So those two right there are almost half of all of the greenhouse gas emissions from the Canadian healthcare system are from drugs and hospitalizations. Everything else is a bit smaller than that. So if you're interested in trying to figure out, okay, big picture, health system as a whole, where should I devote my efforts to try and reduce my impacts, those would be where you might look first. What this table also shows, kind of interestingly, Canada, just like many other countries, including the United States and many around the world, quantify their total greenhouse gas emissions each year from the whole country. And so once you know what it is for healthcare and you know what it is for the country as a whole, you can figure out a fraction there. And it's about 4.5% of Canadian greenhouse gas emissions come from healthcare, which is pretty close to the global average. The global average is somewhere around 4.4%, I think. The United States, if you happen to be in the United States, you can feel really proud. We continue to exhibit American exceptionalism. We are number one. In the United States, it's closer to 9% of our emissions come from healthcare. We also spend more on healthcare in our economy. In Canada, it's about 11% of their GDP. In the United States, it's closer to about 18%. So we can answer these questions. We can also slice the data differently. So here we have it categorized by healthcare expenditure and healthcare category. We can also look at it as, where is the money going? What other industries and emission sources are big? And you see on the last slide, it was 25% was drugs and close to 25% was hospitals. Here we see it's almost a quarter is electricity, and electricity plus energy is about 40% right away, and then everything else is less than that. So really, you see some differences between the country as a whole versus healthcare. So generally, in North America, our emissions are transportation is the biggest category at about 25 to 28%. And then electricity generation is the second biggest at somewhere around 25%. For healthcare in Canada, you see transportation is a lot smaller, whereas that energy remains fairly large. So what we can then also do is divide by pollutant category. And we see climate change. Remember, I mentioned those impact categories to begin with: climate change, respiratory problems, carcinogens, ozone depletion. And you can get an idea then of what are the biggest impacts on humans. So the first step, we talk about midpoint. So greenhouse gas emissions, if you're used to that, kilogram CO2 equivalent would be a midpoint emission, would be a midpoint of what you care about. An endpoint would be, how does that impact humans? How does that impact sea level rise? Or how does that impact our ability to go through our day-to-day lives? As physicians or as healthcare providers, we care about human health. So we can translate these midpoints to endpoints, in this case, disability-adjusted life years. And you see that actually respiratory inorganics, particulate matter, are the biggest impact using kind of the midpoints of the confidence intervals, with climate change kind of second there. So you can get a sense for what are our bigger impacts and which categories might matter more to us than some others. These folks thankfully compared and put the Canadian data into the context of some other countries that had done similar studies. I mentioned the United States is exceptional. Our emissions per capita are quite a bit higher. Australia are also higher than Canada, and Australia has the unfortunate circumstance of their electric grid being particularly worse than North America, with a high reliance on coal. So that becomes a big deal. You also can see kind of what those differences are. Drugs much bigger in Canada as a fractional impact compared to the United States, a little bit closer to Australia. And what are some of the challenges here? So there's no such thing as a free lunch. These studies are great to do, but there's a lot of uncertainty. You can see here there are a lot of steps. The first step we talked about, the input-output tables, then the environmental extension to get those emissions factors, then consumption expenditures, which are tabulated for the entire economy as a whole. And then there's some uncertainty involved in characterizing the midpoints to get from that expenditure to the kilogram CO2. And then that last bit from midpoint to endpoint has huge uncertainty, because honestly, we don't entirely understand or know yet what a kilogram of CO2 does to human health in the long run. We know it's deleterious. I just can't tell you exactly how many disability-adjusted life years that is, and that's why that range is so big. So I hope this was an interesting whirlwind tour of life cycle assessment and what we can do with it. I'll leave you with the question of how we can all be more environmentally sustainable in the care we provide, and I look forward to taking questions later.
That was awesome and really helpful. I think, for folks who aren't doing it all the time, the concept of life cycle analysis and exactly how it's done is a bit of a black box, and so I think this was really helpful in shedding some light on that. Um, um, so I hope you can stick around for a little bit, Jonathan, and we're going to do our second presenter today. Um, uh, so I want to introduce everyone to Dr. Ian Umo, who is from Papua New Guinea. And Dr. Umo obtained his medical degree from the University of Papua New Guinea School of Medicine and Health Science in 2017, and has since worked in a variety of district and provincial hospitals in New Guinea as a medical officer. And he's currently pursuing a master's in general surgery. His research interests have been involved with health economics, and he's published various papers on the direct medical costs of surgery in resource limited settings, which obviously is near and dear to the hearts of many in PGSSC. His research mainly focuses on driving new health policies, and his current work explores climate change and health. Dr. Umo, there was some concern of reliable internet and electricity. So Dr. Umo has created a video that we're going to watch. He's going to talk about his paper entitled Estimating the Carbon Emissions from a Resource-Limited Surgical Suite in Papua New Guinea, the Climate Change Potential. When I spoke with Bethany this morning, she said the audio in the video is excuse me is a little bit quiet. So I just want to make sure everybody's muted so we can hear Dr. Umo.
Hello everyone. Thank you for the opportunity to be able to present on the theme of carbon life cycle analysis. My name is Ian Umo. I'm a surgical resident at Alatau Provincial Hospital in Papua New Guinea. My presentation aims to report on our local carbon emissions from the operating theater. I'll also try to discuss some concepts on climate change and relate it to carbon emissions from the operating theater. I'd like to make mention that there are no conflict of interest in this presentation. I believe it's very important to understand the key elements of climate change before we discuss the role of operating theaters in carbon emissions. And you can see from this flow chart that greenhouse gases cause global warming, which then cause climate change. And when you have climate change, there's an increase in the Earth's average temperature that results in changes in regional and global weather patterns. Now, there's about 6 different classes of greenhouse gases. The most common of these classes is carbon dioxide, which represents about 80% of all greenhouse gases, followed by methane. So when you have a buildup of these greenhouse gases within the Earth's atmosphere, there's solar radiation that is trapped, and this increases the Earth's average surface temperature, giving rise to the greenhouse effect as we know it. Now, greenhouse gas emissions can be measured in terms of kilograms of carbon dioxide equivalent. And in this study, we adopted the greenhouse gas protocol in reporting these carbon emissions. Firstly, in order to calculate this, you must identify a source. So a source is defined as an activity that results in emission of greenhouse gases. It can be driving a vehicle, burning rubbish, or even turning on the light. The second thing is to identify the appropriate emission factor. The role of emission factors is to convert the unit of activity into kilograms of carbon dioxide equivalents. Therefore, if your source of activity is electricity, then the emission factor is in kilograms of carbon dioxide per kilowatt, and so forth. Emission factors can be obtained or provided for from the government or an organization. And lastly, you have to use the appropriate global warming potential. So in terms of global warming potential, you talk about greenhouse gases. So different greenhouse gases have the ability to trap heat differently. The global warming potential is basically the measure of how much heat a greenhouse gas traps in the atmosphere relative to carbon dioxide. So you can see from the graph that methane traps heat 25 times more than carbon dioxide. Likewise, nitrous oxide traps 300 times more heat than carbon dioxide. So depending on what activity you're reporting, the appropriate global warming potential must be used. When you think about annual global carbon dioxide emissions, rates have dramatically increased since the industrial era. We have emitted over 1.5 trillion tons of carbon dioxide, and levels are now 50% higher than ever. The health sector in particular contributes to 4.9% of the total global greenhouse gas emissions compared to agriculture, transportation, mining, etc. So why do we investigate carbon dioxide emission? The simple answer to that is doing surgery is a source of greenhouse gas emissions. So despite the health sector only contributing to 5% of the global emission, there is still an obvious need to increase primary surgical services in low to middle income countries like Papua New Guinea. So in these low to middle income countries, that is where you find 90% of the burden of surgery. If you increase these surgical services there will be an inevitable increase in health sector emissions. That is why in low to middle income countries, it is important to understand how much carbon dioxide emissions we are giving off into the atmosphere if we are to be truly serious about climate change and healthcare. Our aim of this study was basically to estimate carbon dioxide emissions from the operating theater and give some recommendations on how to reduce these emissions. Our research team was made up of local researchers, local health workers. So on your right hand side, you can see this is Margaret. She's an anesthetic resident. We have John, who's an obstetric resident. And then you have Tepoka and Amos, who are operating theater nurses. So this team were involved in collecting of data and analysis of the research. We did not have any international collaborators, but I'd like to make mention of Dr. Quinn and the team who published a paper in Lancet in 2022 discussing the role of surgery and carbon dioxide emissions in the Western Pacific region. And that paper more or less gave us the idea to conduct this research. And also the work done by McNeil, Lillywhite, and Brown that laid the format to help us conduct this research. So this research was conducted at Alatau Provincial Hospital. The hospital is the only surgically capable hospital in Milne Bay Province of Papua New Guinea. It serves a largely maritime population of about 400,000 people. The surgical suite itself is about 740 square meters and has 2 operating theaters. So this was basically a prospective carbon footprint study that was conducted over 3 months. In this study, we adopted the greenhouse gas protocol to report carbon dioxide emissions, and these emissions are reported in terms of 3 scopes. So you have scope 1 that refers to direct emissions from the activity of the organization. Scope 2 accounts for indirect emission as a result of electricity consumption, and scope 3, which includes all other indirect emissions occurring as a result of or a consequence of the organization's activity. Therefore, as per the greenhouse gas protocol reporting system, the operating theater activities were divided into 3 scopes. So scope 1, we looked at anesthetic gases. Scope 2, we looked at electricity consumption, and scope 3, we looked at waste disposal. So in scope 1, in order to calculate the emissions from anesthetic gases, we had to um, get each of the anesthetic gas volume, density, and respective global warming potential to calculate the carbon dioxide produced for each of the anesthetic gas that was used. And the formula we used is as shown. In terms of scope 2, electricity, we obtained the total power used over the study period, and we calculated how much carbon dioxide was produced using the formula below. Now, ideally, each building should have a meter that tells you exactly how much power is being used. Unfortunately, in our hospital, we couldn't do that. We don't have a meter on the buildings. So in order to obtain our total electricity consumption for the surgical suite, we had to estimate by using a location-based method. So what we did was we first measured the area for each building in the hospital and then represented the area of the surgical suite as a percentage of the total area of the buildings, and then multiplied that with the power consumption of the whole hospital over a 3-month period. And that gave us an estimate of how much power that was used by the operating theater. So basically this was just an estimate. So power consumption of the hospital was provided to us by our local power provider, which was PNG Power, and they use diesel for power production or electricity generation. As such, we use the carbon dioxide emission factor for diesel to calculate our carbon dioxide emission. For scope 3, we looked at waste disposal. So an audit of the upstream waste disposal was done during the study period. We weighed and cataloged for plastics, sharps, and we used the above formula to calculate, the formula given below to calculate each of the carbon dioxide emissions. So all wastes were transported in landfill, so we also calculated carbon dioxide emission for transportation. This research was approved by the research committee here at Alata Provincial Hospital. We did not have any funding for this research. We did not receive any grants. In terms of our results, just to give you an idea of the type of operations that were done over the 3-month period, in total we had 360 operations that were done. During this time, we had a visiting ophthalmology team that came and did some cataract surgeries also. But our top 10 surgeries performed included tubal ligations, excisions, exploratory laparotomies, cesarean sections, and INDs. Now, the majority of these patients had undergone general anesthesia, followed by local anesthesia and sedation. And in terms of the 3 different scopes, in terms of scope 1 emissions, the 2 main gases that were used were isoflurane and halothane, and the total emission from these gases were about 1.1 tons of carbon dioxide equivalent, and the majority of that came from isoflurane. In terms of scope 2 electricity consumption, we found that 553.8 kilograms of carbon dioxide equivalents was emitted over the study period. In terms of scope 3 emissions, we looked at cardboards, average plastics, polypropylene, sharps, and transportation of waste. We found that we had emitted about 894 kilograms of carbon dioxide equivalents over the study period, and the majority was from just transporting of the waste products to be landfilled. So you can see now that scope 1 had the highest in terms of greenhouse gas emissions, followed by scope 3. And to put things into perspective, the total carbon emissions during the study period produced was about 2.6 tons of carbon dioxide equivalents. That is the same amount of carbon dioxide that would be produced by doing a 2-round trip to New York from Paris on a large passenger jet. We also calculated that for every surgery we did, we would emit on average about 8.3 kilograms of carbon dioxide equivalent into the atmosphere. Now, if you were to extrapolate that uh, um, data, we would have emitted in 2021 over 20,000 tons of carbon dioxide equivalents into the atmosphere in our operating theater alone. Now, by way of discussion, I think this was a very important paper that was published in the Lancet by, as mentioned earlier, McNeil, Lillywhite, and Brown. And they also looked at 3 different operating theaters in high-income countries. Obviously, these hospitals that they investigated had higher surgical volume compared to our hospital. They had different um, sources of energy production and different waste disposal methods. But the main difference in this study compared to us was the rate of carbon emissions from the 3 different scopes, which was more than 100 times um, compared to the emissions from our study. So even despite emitting less carbon dioxide into the atmosphere compared to operating theaters in high-income countries, we still expect that emissions will increase with the forward aim of increasing surgical services and specialist surgical services in low to middle income countries and in Alatau Provincial Hospital. Currently, there is an existing framework that helps to increase our surgical service delivery. But you can see that none of this accounts for climate change adaptation and mitigation practices. So how can we reduce emissions from the 3 different scopes that we just reported on? Scope 1 anesthetic gas recommendations include, reducing the use of anesthetic volatile gases. And currently, I haven't read any studies that show that general anesthesia with gases improve outcome when compared to TVET anesthesia. We must encourage more cases to be done with regional anesthesia and installation of a scavenging system that captures and recycles volatile anesthetic gases. So in our operating theater, we don't have a scavenging system, and that was something that we highlighted and we're trying to push for in our hospital. In terms of scope 2 recommendations, simple things like turning off the lights and machines that are not in use. We are trying to install a building meters to properly audit the electricity usage of the operating theater. And I think the way forward is renewable energy to reduce carbon emissions in the operating theater. In terms of scope 3 waste disposal recommendations, we should encourage the use of more green-friendly medical consumables, increase the use of recyclable consumables, and adequate packing of trays so that during surgery you don't open extra trays that will require more time to sterilize the packs that were initially open and increase the carbon emissions from that activity alone. Now, this study has various limitations. We did not have any local emission factors, so we had to get emission factors from previous studies that were done, and we did not have full access to certain sites to get proper emission factors or the latest emission factors because of our funding issue. Also, we had a smaller sample size and surgical volume. If we don't address climate change, it will affect our health. Extreme heat can cause heat stroke. Natural disasters can cause injuries. Flooding can cause loss of food crop and pollution, and this can lead to malnutrition and diarrhea. When people migrate because of rising sea levels, they are faced with social problems that can lead to injury and poverty. And those are all things that we are currently seeing in Papua New Guinea right now. Also, recently in PNG, we have seen a rise in dengue, chikungunya, malaria, reemergence of polio, and these have all been attributed to a change in vector ecology as a result of climate change. So it's very important that we take seriously our contribution to carbon emissions from the activities that we do in the operating theater. Climate change affects everybody. It's global, and I believe in Papua New Guinea we shouldn't play victim to climate change and say that, um, because of high income countries emitting a lot of greenhouse gases that we are suffering. We should take or we should be proactive in our practices in mitigating and adapting to climate change in order to be more resilient and to reduce the greenhouse gases we emit from where we are with the activities that we are doing. Only then can we make climate change a health priority moving forward into the future. Thank you.
That was great. I don't know if Dr. Umo has been able to join. Dr. Umo, if you're on, can you say hello? I think unfortunately the problems inherent to consistent electricity and internet access in places like Papua New Guinea are unfortunately foiling our ability to have a further conversation with Dr. Umo. So if he joins, I hope he'll be able to offer some insights and answer some questions. So Bethany has put up the results of the Menti poll. So in the chat, she's asking if you don't see your location being represented, please click the link that she posted in the chat and note that. All right. Well, Dr. Slutzman is still here. And I remain hopeful that Dr. Umo will be able to join. But I wanted to open up for the last little bit here to some discussion. And if anybody would like to ask Dr. Slutzman a question, please feel free. I can start. I have some stuff that I am curious about. So in the Canadian paper, it clearly makes the point, and the whole emphasis on the paper is on system, the Canadian healthcare system. And the responsibility of the system for admission and Dally's lost and all that sort of stuff. To me, this is clearly a policy issue. Yet we seem to persist in like promoting this idea, and I mean sort of the royal we, in that there's a lot of responsibility for individuals to act. You need to put solar panels on your house. You need to get an electric car. You should bike to work when you can. And while all of those, I believe, are good ideas, my personal feeling is you're not really going to move the needle until there are real policy efforts that are happening. I'd love to hear your thoughts on that and how we get to that point of actually having more climate-friendly policies around healthcare in general and surgical care in particular.
I see you're starting with the easy question first, Craig. And I think what I'll do is, to some degree, I'm going to take off my hat representing Mass General Hospital and Mass General Brigham Health System. For the answer to this particular question, I am not speaking for my employer. The pressure on individuals to solve this problem has been around for decades. I grew up at a time when recycling was just nascent, and we were definitely given the idea that if we just all recycled, the world would be fine. And it was each individual's responsibility to sort our trash and take it out to the curb in our recycling bin. And wasn't that so cool? And we're saving everything. Um, I'm I'm not going to say that it doesn't help, but you were sold a bill of goods. It doesn't actually do what we all thought it would. And we have evidence that at least in healthcare, particularly in perioperative services, if you maximally recycle everything in the operating room as an individual or a health system, you're improving your environmental performance with respect to climate by about 1%. So not a huge improvement. Overall, if you look at the climate crisis and what we can do about it, about half is potentially actionable by individuals. And the other half has to, by necessity, be done by larger entities, whether that's government or industry or some other really big group beyond an individual. Some things have bigger impacts than others. And I say this because really the individual factor here is by driving a market, that as long as people want to eat red meat 4 or 5 times a week, there will be a market for it and people will provide it because that's the way the market works. So if people eat less red meat, then it will create less of a market and it will reduce those emissions considerably. So food choices matter, but they matter more in aggregate than they do as an individual. I think that the probably easiest solution is really to take this textbook case of a negative externality and internalize it, and that's through taxing. That this is a if you open a simple Econ 101 textbook, I remember many years ago, my Econ 101 textbook was written by a very conservative economist here in Cambridge. And pollution was the textbook case for a negative externality that needs government intervention to internalize the cost with taxes. So basically, tax the pollution. If you tax the pollution, then the producers who can produce products with less pollution will have a lower price and the market will respond to that. And that becomes more palatable for everybody, including healthcare systems, where we operate on fairly tight margins, and a lot of our decisions have to be made based on, at least partially, financial considerations. In addition to clinical effectiveness, safety, infection control, sustainability, and resilience, but the financial factor is very large. So I think that is part of the answer. I think advocating in an apolitical way, we as healthcare providers, particularly physicians and nurses, have very trusted voices. Nurses are consistently rated #1 in terms of trust in society, at least in the United States. Every year, with the exception of one in the last 25 years, nurses have been #1 in that survey. Physicians are generally somewhere between 2 and 4. So we have a trusted voice. We can speak about climate change as a health concern, not having anything to do with politics, right? It doesn't matter where you are on a political spectrum. We talk about it in terms of protecting human health to try and change those policies. As healthcare institutions, we can also move the market by putting pressure on our suppliers, which is something that we definitely do at Mass General and Mass General Brigham, to get our suppliers to provide better environmental data on their products. The UK NHS is taking the lead here as well, so that we can make those decisions taking more and more sustainability into account. But it's not easy. It's culture change takes a long time. I've been at this at Mass General for about 6.5 years, and we're just now really seeing the culture change among many of our decision makers.
Thanks. I didn't mean to, ask you the big question, but I guess I did. So sorry. Thank you for a thoughtful answer. We have some questions in the chat. Laith, do you wanna ask your question, or I can ask for you? All right, why don't I ask? First question is, considering the significant environmental impact of surgical services is highlighted, are such factors being systematically integrated in the development of NSOAPs and LMICs?
I'm gonna admit my ignorance and not know what an NSOAP is.
So I can actually address this. NSOAP is a national surgical obstetric and anesthesia plan, essentially a policy document that lays out sort of high level approaches to development and maintenance of surgical systems. So there are a limited number of NSOAPs right now, and in most, if not all, of the existing NSOAPs that I know of, there's no consideration of climate change. What I will say is that several of the Western Pacific nations are going through national surgical planning processes, and the Western Pacific region in particular is acutely concerned about climate change. It is an existential threat for many of the island nations. And as such, there are a lot of climate considerations within not only just ENSO planning, but at the Ministry of Health level in many of these places. We actually have a big project working with the Pacific community and Pacific Island nations looking at healthcare and surgical care vulnerabilities due to climate change. So in terms of the other existing NSOAPs, there's really not much, if any, in there on climate change. It's not really a consideration. The other question is, how can healthcare systems, specifically those in LMICs, measure and track progress in reducing their environmental emissions efficiently?
Yeah, so that's a question that's directly up my alley. A huge part of my job is figuring out how we are measuring and reporting our environmental impacts from our hospital and health system. And there's little reason that lower and middle income countries couldn't do it. The tools exist. There are some data acquisition challenges. As Ian mentioned, we talk under the Greenhouse Gas Protocol about 3 scopes of climate change emissions: 1, 2, and 3. 1 and 2 are actually very, I almost don't want to say very, but really they're easy to measure. They take data that you're likely recording anyway. Things like, how much electricity did you buy? How much gas did you buy? How much anesthetic gases did you buy? Things like that you have those data already, and even if your utility doesn't necessarily give you an emissions factor for your electricity, you can use global averages or country averages that are available and get a pretty good measure, even down to the individual healthcare institution level, let alone at the national level. So that's not terribly hard. There are tools available that you can find online. Even you can even use ones from other countries, because a lot of the stoichiometry is going to be exactly the same. Whether you burn a therm of methane in Boston or you burn a therm of methane in Uganda, it's going to be the same carbon dioxide emission. You might be a little different, a little bit off as we get into the upstream impacts that are more scope 3. But for the most part, your scope 1 and 2 are going to be right on. Scope 3 is a lot harder to quantify, and right now we use the biggest pieces of scope 3 are purchased goods and services, and we use an economic input output model for that with spend-based data. that are just notoriously inaccurate. So we're a bit harder. The actual calculation isn't hard. If you know how much you're buying and what the devices are, you can categorize them and come up with a spend-based model. Again, there are free online tools to do that. And with a global supply chain, the answers that you're going to get are going to be pretty close to accurate. But it's overall a more fraught area. So I would advise anybody who's really interested, start with scope 1 and 2, get a hang for it, and then you can move on to scope 3.
Awesome. Thank you. So there's some people who have their hands up, and maybe Afra can go first, and then Bethany and Gabriella. You're muted, Afra.
So much. Hi, my name is Afra. I'm one of the fellows at the PGSSC this year. Thank you so much for your presentation. I just wanted to ask a question about sort of a follow-on to what you were discussing before. In terms of like hospital taxation, I'm from the UK. I feel like our NHS doesn't have any money anyway. So it feels like a curious solution that I'm sure doesn't apply. Like I can understand how that might work in private healthcare systems, but in social healthcare systems, which I hope lots of nations are moving towards, like, is that like the right, well, like what are the alternatives when that's like taken into account? And then within that, I guess like often like our NHS is so sort of underfunded that we are really encouraged as individuals to try and make contributions where we can. And I know that you've said that carbon emissions from that are attributed to individual change or individual choices are like quite small, but sometimes it does feel like if we maybe all use less or are more considerate in our choices, that we would, obviously it's nice to feel like you might have an impact. And one of the things that we talked about in our journal club earlier in the week was how maybe like as surgeons, there's a bit more, you have more capacity to make change just because you know, well, I guess you are maybe responsible for the running of an operating theatre over the day. And there's lots of individual choices that can be made within that, and coming down to the equipment that you use and the way you run your OR, that feel like it might be a significant thing to do. I guess really, I don't really know what the question is in this. It was maybe just like, did you have any thoughts on those things at all, or should we really just not bother and just focus on trying to get our hospitals to be more accountable?
Yeah, I'll try and touch on these as best as I can. There are two answers to the challenge of essentially carbon tax and the fact that the NHS is underfunded. They, for the most part, they are unrelated problems. In the sense that, first of all, you have the advantage in the NHS that the NHS already has policy mandates for decarbonization. And it is costing the NHS to do that, as in they're going to end up buying products that will cost more because they are environmentally superior. So to some degree, this harms the NHS by not being able to reap the benefit of lower priced, environmentally superior products. And the answer to a carbon tax essentially not being regressive and hitting the folks who can afford it the least, the hardest, is something that Canada has done in many provinces. And that's a tax and dividend system, where essentially the tax is based on the emissions. And so it becomes a consumption tax, and that the more you consume that emits more pollutants, the more you're going to pay of the tax. But the dividend is not consumption based. The dividend could be in a flat method. It could just be per capita, where you would just take the total tax revenue and divide it by the number of people and return it, such that folks who consume less will actually potentially end up getting more back than they put in. And the folks who consume more will clearly be putting more in than they're getting back. Or you could turn it into a progressive tax and actually rebate it in an environmental justice kind of way, to in some ways repay the people who have suffered more of the environmental burden historically. I'm not advocating for one or the other, but the system can be designed in such a way that it doesn't do that, and then essentially it would be likely zero sum for the NHS because the NHS funding could be increased by the same amount that they end up having to pay in the tax, which then gets rebated back to the people who are paying the tax anyway. So that's a feasible way. Now, as far as the role of the surgeon and how you can be most impactful, you are correct in that operating theaters generate, we think, and I'm only able to use the data that exists. So in terms of waste, operating theaters, we think, generate about 30 to 40% of the total waste of a hospital, which is pretty remarkable given the area that an operating theater occupies compared to a whole hospital. It's about 30 or 40% of the waste. So you can extrapolate and say, well, it's probably a similar or rough order of magnitude, same amount of pollutant. And that's probably true. So how you run an operating theater can certainly impact that. So simple things would be maximizing reusable supplies. There are lots now of life cycle assessments looking at disposable versus reusable equipment in healthcare, much of it in perioperative services. And I will tell you that nearly all of those studies show conclusively that reusable devices are environmentally superior to disposable devices. The very few studies that come to a different conclusion, almost all of the ones that I have read have fatal flaws in the methods that I wouldn't conclude anything from the results one way or another. So I feel very strongly that with our current energy economy around the world, disposables are environmentally worse than reusables. If you were to pick one blanket rule and not do any kind of underlying study, that would be a good one. It's not going to work perfectly all the time, but it's going to work good enough for you to do it. And that's something where surgeons have a lot of power and control in the purchasing department. It also has the benefit of being more resilient in that you don't need to worry as much about global supply chains collapsing in the face of a theoretical pandemic. The other way to look at it, and I and my colleagues who are medical directors of sustainability, we know of about 18 of them across North America right now. We look at it as the most environmentally responsible surgery you can do is the one that you don't do. That doesn't mean patients shouldn't get care. It means we should create healthcare systems where they don't need as much care, where they can remain healthier, where we don't need to do as many things to get people back to a state of health that they hopefully stay healthier for longer. And an example there is a study that I need to do some revisions after we got comments back from reviewers, looking at the climate change impacts of care for patients with chronic kidney disease, where we very clearly can see, looking holistically at the healthcare that they consume, that patients in higher stages of chronic kidney disease are responsible for larger and larger environmental impacts on a per patient basis. And that ultimately peaks at dialysis. And along with dialysis comes fistula and graft placement. So surgery counts in there and it's included in our model. So wouldn't it be better if we just made it so that patients who are in, say, chronic kidney disease stage 3A do not progress so quickly to 3B and 4 and end-stage renal disease and don't need all these other interventions? So creating that healthcare system that minimizes care, but not in the way of oh, we're going to let you die, more that it minimizes care and that you don't need it, and also reduces low value care. So let's stop doing things that really aren't improving people's health as much as we can. So that's kind of the big picture of the roles that we as clinicians, particularly proceduralists, can do.
I would just add, from the NHS perspective, the NHS is trying to do some systemic things driven by strong advocates, and I know this area best among the anesthesiologists. The AAGBI has really been at the forefront of considering the environmental impact of surgical care, and so I would there's a growing surgical movement, I think, that is also concerned about that. But if you want to see where you can try to move the needle within the NHS, I would encourage you to reach out to folks at the AAGBI, because I think they've done a nice job with that. For example, the NHS has banned desflurane, and so desflurane is essentially, if it's not, I can't remember when that goes into effect, but it may have already happened. But basically, the worst inhaled agent for the environment is no longer utilized, or will no longer be utilized at NHS hospitals. The NHS has paradoxically demonstrated that, for example, single-use drapes and gowns are not only have, as Dr. Slutzman was saying, a clear environmental problem, but they are more expensive, and as opposed to multi-use gowns and drapes, and there is essentially no difference in infectious risk. So part of it is getting the message out of what data exists to decision makers, and advocating for that. So we only have a couple of minutes left, so I would let's see. So it looks like Dr. Slutzman has addressed Kate's question in the chat, and why don't we go to Gabby, and then Jackie has posted something in the Q&A that I will try to address. But Gabby, if you want to go ahead and ask Dr. Slutzman your question. You are muted, my friend.
Sorry, I'm just
Yeah,
Can you hear me?
great. Thanks. Sorry about that. We're all in the same room, so we wanted to try to reduce the reverberation. But the question essentially is kind of linked to the methodology and some of the things you said about shifting,
I lost you there.
I think you're just muted.
no, it was working.
Sorry, I thought you were using yours.
Okay, no, it's okay. Essentially shifting, a lot of focus in the past has been on individuals, whether it be an individual practitioner or an individual hospital facility or service, to try and take responsibility and feel empowered, I guess, in reducing emissions. Is there a way that this methodology could be applied to specific service components of the health system, or does it rely on too many, I guess, like aggregate measures in terms of the life cycle of the health system? So how could we, more objectively evaluate impact, and can we scale the model down, I guess, to look at it on a more granular level? And part of that question, like baked into that question, I guess, is contexts where there might not be the system-wide data available at the same scale that is available in health systems like Canada, the US, etc.
Yeah, good questions. And you get a bit into the challenge of the challenges inherent in the method, and where process LCA bottom up and economic input output LCA top down, where they kind of meet is a hybrid model. There are LCAs done that are explicitly hybrid, where some pieces of the model are done using process methods bottom up, and some pieces are done economic input output or EIO top down. The top down method really works best when you're looking at large swaths of an economy. It fails the smaller the scale becomes. So, for example, when we talk about using a spend-based model of our emissions associated with purchased goods from Mass General Hospital, what we're basically saying is that if I spend $1 million on medical supplies, that the proportions of medical supplies within that $1 million at MGH are the same as the proportions of medical supplies in the US economy as a whole. We know that is not true. So the emissions factor is going to be off. How far off? I don't know. The other problem that you get with that kind of a model is over time, that say there's a particular device. Let's say there's I don't know, some electrophysiology catheter that we use that weighs, I don't know, 100 grams. And it's mostly plastic and it's got some other parts, whatever. And it costs $800. And next to that, I have a bag of saline that weighs, 1,100 grams and costs $4.50. The model is going to say that the emissions associated with the catheter are 20 or 200 times bigger, just because it's spend-based and they're in the same category of medical supply, even though we know that's entirely not true, 100% not true. The third way it gets to be wrong is, say I have that bag of saline and I decide to switch from a regular bag with our regular supplier to one that's from a more environmentally friendly supplier, and the plastic doesn't have DEHP in it and all sorts of other things that environmentally are better. It weighs the same amount, but now it costs 15% more. My model is going to say that the emissions are 15% higher, even though I know that I purchased this product because it is environmentally better. So it's a flaw in the model to use EIO at a small scale. And so we try to make up for it by using process as much as possible. The smaller your study, the more you should be using process bottom up, which can be done in a way using globally available industrial data. So there are data sets that I use. I don't necessarily ask every manufacturer what are the emissions associated with making this extruded plastic straw. I'm gonna use kind of industry averages, which have some error, but at least it's close enough. So you can do things like that. And then for bigger scale things, we did a study looking at radiation oncology treatment, where we could model process-wise a lot of the individual steps, but the linear accelerator itself, we couldn't take apart and measure each piece. And the manufacturer wasn't going to tell us all of their emissions. So that part we used economic input output spend-based, whereas the rest of the model was process. So that's a hybrid model, and it becomes more valid when you amortize the really large item over a lot of uses. The really short answer is LCA is hard. There are a lot of individual choices to be made, but it is the most powerful tool for answering these kinds of questions.
Well, this was awesome and very enlightening. Dr. Slutzman, thank you so much for taking the time, especially after you worked all night. And there's nothing more fun than to come and do your academic stuff when you're exhausted. So I really appreciate it. I am really sorry Dr. Umo couldn't join us, but I think what I'm left with is, obviously there is a ton of stuff to talk about and think about around this. And I would encourage any of you who, this may have sparked an interest to come to our COAST meetings. which Callum sends out to everybody. And you know, you guys are welcome, and I think there's plenty of stuff to do. So I would encourage that. The last thing I want to close with is the next research seminar is going to be on December 14th, and it's going to talk about building capacity in pediatric surgery, and the need, quantifying the need for pediatric surgery worldwide. So as a peds person, another, in my opinion, crucial topic. Anyway, I would encourage you to make sure it should be the same link to register for that. But if you guys have any questions, please reach out to the research team. I'll just close in once again thanking the research team for having me moderate this, but also for Dr. Slutzman coming and talking about this and really enlightening us as to how we think about quantitating environmental impact, as well as some things that we can potentially do and advocate for to improve our environmental impact and on surgical care and health. So thanks very much, and I think that's it.